start it again. Let's just see. You can say hello.
So there is someone online?
I just refreshed my screen to see.
Okay.
Oh, here's chat. Yes, I can see them now. Yes, there are 4 people online.
Hello.
And I will say, please introduce yourself.
Yeah. But we can't even hear them audio.
No.
No.
No, webcast is just
We're a
chat.
little further advanced, aren't we?
Okay. I just asked them to introduce themselves and we'll pass it on as we hear.
All right. The other thing is ask them if they have a computer in front of them with a webcam. Any one of them.
If you heard what Elsa just said, does anyone have a webcam on their computer that they're using to watch the webcast? So you can let me know. And in the meantime, Diana from Nova Scotia is online. Dr. Diane Holmberg is a professor at Acadia in Wolfville, Nova Scotia, and she says hello.
Okay.
And she says yes, she has a webcam.
Oh, good. Because in the second half, we're going to have folks, one person online, one person here, to actually join a video conference meeting on the website. So you get a sense of how that works.
And I can tell you the names of the other people that are here, just so you know. Natalie, who I assume is Natalie Kidner, who's a psychogeriatric resource consultant from NSM, Collingwood General Hospital. And also online is Christina, who's Christina Darlington, a regional manager from VHA Home Care. Also online is Valerie. Valerie Powell is the coordinator at NSM Behavioral Support Unit in Waypoint Center, at Waypoint Center.
Where's that?
Penetang.
Oh.
Penetanguishee. And Michael Liu just joined, and he's the director of Nurse Next Door Home Care in Etobicoke.
Okay.
Welcome, everybody.
Okay, so let's get started. And what I thought I'd do for the first hour or so is really give you the background as to how this all developed. And going through 3 clusters of studies that we've done. And as we go through, it'll tell you all about the web platform, the content, and how it works. And then in the second half, I'm going to invite you to tell me what kind of program you want to deliver and how that would look using our platform. And also give you the opportunity to join a video conferencing meeting. So Joanna has set that up. She's going to give you a username login to the website, and you will join the video conferencing meeting. Now, for the online people, we know at least one has a webcam, so maybe we'll invite her to join, and we will tell her what is the name again?
Diane.
Diane will tell you a username and password that you can use so that you can join the video conferencing. Okay. So I started this work about 12 years ago, and I was right from the start, and I've continued to be interested. The main focus is, can you transition a intervention program that you deliver face-to-face reliably to an internet environment, and does it yield the same results? So that's been our question throughout all the studies we've done. So when we started, this was the first version of our program, and we had disease-specific handbooks. We still have, At that time, the first study was with caregivers of people with dementia, stroke, Parkinson. And so we had 3 information handbooks. In that version of the web platform, there was an email module, and it listed the names and email addresses of the people in the group, as well as the group facilitator. Then there was a threaded discussion group. This is like any chat forum, text-based, so that people could go on anytime, pose a question or make comments or whatever. And that was asynchronous. It wasn't at any set time. And that was just so that people could engage with each other than when they were meeting online. We met online weekly for 1 hour with a trained facilitator and for 10 weeks. Now the video meeting, you could do one-on-one or group. In addition, we had some educational videos and animations, neither of which we use now, but we did various studies to look at how the participants responded to these kinds of materials. And let's do it. Yeah. So the support group for caregivers has always had this particular approach. Understand the psycho, social, and physical health challenges of caregiving, bond and share common experiences, develop goals, plans for implementing care and self-care strategies. We found...
I'm just going to ask, will we be receiving the PowerPoint?
I can send them to you.
Oh, wonderful.
Yeah.
Thank you.
What we found is underemphasized in a lot of the support care models for caregivers was self-care. There was a lot of emphasis on particular issues that needed to be dealt with, especially when dealing with caring for dementia, and much less in self-care. And so we tended to emphasize that a lot. Now, the website design, security, and validity. This is a big issue because we were designing a website that would be easy to navigate by older adults who had never used computers. And when we started this project, I would say 90% of the caregivers had never used computers. We supplied the computers, we supplied internet access, and we trained them. And so the design had to be very simple, and we'll show you the initial design and the current one. Ideas for the web design, we got, there were some criteria developed by IBM, by NIH, the American Granting Agency, and so we used those, but we did got a lot of feedback from the initial users. So what we did is we had a group of caregivers, dementia caregivers, facilitated by a social worker at Bakeress, who met face-to-face for several sessions. Then we took them in a lab with computers, and then they started to meet using the computer and webcam. So we trained them in this lab. And then we kept getting feedback from them, sort of as we went along, in terms of the experience of now communicating using. Because in the next stage was to do it at home. So we went from face-to-face, lab, home. And all of that was used then to continue to develop the website so it was really user-friendly. Now the security is extremely important. And I must say that a lot of the programs for patients, caregivers, online, I don't think pay enough attention to security. For instance, if you use Skype, it's not secured. Okay? If you use email, it's not secured. And so we have to really find ways to communicate where the patient is as protected as they would in a face-to-face clinical interview. And we must really attend to the ethics of providing care in a technology environment. As you know, things can go viral. And so the last thing you want to happen is that any information, especially in a video conferencing environment, is hijacked or invaded by any. Encryption, it just means it jumbles everything so that you can't get any information. Now, with the video conferencing sessions for the research, we archived them, which meant we could copy them, download them, and then we did an analysis on them. But they were always removed from the server, and they were subsequently destroyed. But for you and the current platform, you would never archive. You would never save the sessions. There would be no point. And you would have to assure your clients that, you know, whatever happened in the video conferencing environment would be gone at the end of the session. Simply would not remain on the server. The content is has been these information handbooks, which are disease specific, and so we say they're empirically and clinically validated. In other words, the information in them is empirically based and clinically sound, which means we've had them vetted by experts in each of the disease areas. And they will also need to be constantly updated to stay current with what is happening in terms of any particular disease category. Computer training manuals. Well, we've probably done about 10 versions. Because, again, it had to be very simple for people to follow the manual in order to understand how you log in and how you navigate the website. And so the current version, I think, is as simple as it can get. And we'll show you later, Joanna will, that we've even done now what we call a cheat sheet, which is a simple guide. And so if you just follow along there, you probably have smooth sailing. What we cannot control for, and you never be able to control for, is their service provider in terms of internet, the server, and their computer, and which browser they're using, although we always advise which browser to use. That they should be hardwired and not in Wi-Fi and these things. But that's about all that you can do. You really can't have, control. And then the intervention training manuals. Probably the best known one is CBT, cognitive behavioral therapy. It's probably the most standardized intervention exists, with tremendous amount of empirical evidence as to its efficacy. But I don't know of many other intervention manuals that really tell you how to carry out an evidence-based model of intervention. What does that mean? Simply means that this intervention has been tested repeatedly over time and yields the same results. So it means you can train clinicians to adhere to the model reliably and generate the same results. Okay? So you need to do it in a face-to-face environment first, and then when you transition, you then test it again to see if it works online. So the training manuals are a result of that work, that we describe what happened face-to-face, we tested it, we then described what happens in an internet environment and tested it, and found that we were able to train clinicians and that they adhered to the model and that it yielded the same results. Okay. Now here's what the intervention is about. Nothing new, basically. It's what you do in most support groups, okay? There's ours is unstructured. Many of them, as you know, especially support groups for caregivers, are structured. In other words, there are topics, handouts, and each week they discuss a topic. Now, we tried that in a face-to-face environment. But what we found was that eventually caregivers would talk about each of these topics, but when they wanted to, not when we wanted to. So for that reason, we decided then it was unstructured. So the way it starts is they come in and they tell their stories about what they're doing currently caregiving, who they're caring for, what stage of the disease they're at, what the demands are, what their concerns are, and so on. We found by doing that, they engage in bond almost immediately. Because basically, their story reverberates with someone else's story, and we found that it was very powerful in terms of getting the group engaged and willing to really share some of their really most painful reactions to being caregivers. So the focus is on understanding emotional and psychological responses to disease diagnosis, treatment, and caregiving tasks. Identifying the barriers to information process, goal setting, planning. Now that sounds pretty fancy. All it is how do you deal with denial? Because what happens is some emotions, and I think for caregivers, the most troubling emotions are frustration, anger, and guilt. And if you don't acknowledge them, if you don't deal with them, then you go into denial. And they function as barriers. And the primary barrier is really to self-care, and if they don't take care of themselves, they cease to be able to take care of the care recipient. So it's a circular kind of issue in terms of how important it is to understand what they're experiencing. Manage the conflict between meeting caring goals versus self-care goals. This is a big issue. We found that whenever the facilitator might engage on thinking about self-care, there was a lot of resistance. They simply didn't want to deal with it. They felt their primary responsibility was caring, and that they were at the bottom of the list in terms of caring for themselves. But then they began to talk about both their health issues, their personal health issues, their sense of isolation, their feeling that family that you would expect to be supportive weren't there for them, that they were highly stressed, and that they were really in quite vulnerable, risky situations for themselves. And from that, they gradually came to acknowledge some of these feelings and understand how they really got in the way of taking care of themselves and ultimately taking care of the care recipients. Then we promote strategies for electing realistic goals and steps for goal achievement. We've come to emphasize this more and more over time. And what it has to do with, for instance, I'll give you some examples. We had, I remember early on, a caregiver who was quite a good pianist and loved to play the piano. And she stopped playing. And the reason being, she just was too busy caring, and she also loved to go, obviously, to piano recitals, concerts, and so on. Stopped doing it. And so we began to get her to talk about that. And so she had blanked it out rather than being able to say, when might I, this week, fit in 15 minutes at the piano? Okay. How might I go to this concert? What are the steps in being able to do that? And so gradually she was able to do that. So you have to think about, if you thought of her goal initially, when she had to stop everything, it was an unrealistic goal because she couldn't continue to play the piano every day as she used to or whatever. So she had to set a goal that was doable but would still give her lots of gratification. So that was the way they began to do it. The other biggie was taking time off for themselves, either getting someone in to substitute care or going into brief care or whatever it's called.
Adult day programs.
Sorry?
Adult day programs.
Day programs, but also their residential programs, short-term
Respite care.
respite care. so that they could take a week's vacation. And so, gradually then they could be able to set the goal and go through the steps of, how they might achieve them. The big outcome was enhanced self-efficacy and control over caring tasks and self-care behavior. We did a study where we surveyed about 300 dementia caregivers. And we had them fill out a lot of questionnaires on depression, on general health, on social support, on self-efficacy, just a whole bunch. Just see what was the strongest predictor to their health status. And self-efficacy was a big one. In other words, the more confident a person felt to be able to take care of the person, to execute the task, and to care for themselves, they're better their health status. And so we've now kept that in our evaluation package, which I'll talk about later. But it also asks the question, can you improve self-efficacy through the intervention? And you can.
When you say people didn't do good goal setting, was it because they didn't know they had choices, that there were things like respite and adult gate aid programs, or just did they really think I can do it all?
No, they would either not set them because they felt they could no longer go there, like the pianist, or they set unrealistic ones.
Yeah, I was just wondering why, because they didn't know there were some choices that they could make, or they just took it on.
I think there's a tendency to overshoot the mark, generally. And
So in talking to some of the parents of children with long-term illness, often they don't know where the resources are.
well, that's true.
Yeah.
Yeah.
So they continue to do it all and have very unrealistic goals, but because they felt they had no choice.
Yeah. Yeah. But that's another issue. That it really is they're not having the information as to what resources there are.
They're unrealistic goal setting.
Yeah.
Is that the gap?
Yeah.
And I just might, if
Yeah.
you could maybe repeat what B is saying. I'm not sure that people can hear. Sorry, B.
Well, I'll repeat it. What B was saying is that people don't set goals or realistic goals because they don't know what their options are, but uses an example what resources might be available to parents of children with long-term disabilities but that's a different issue, lacking information, because certainly you can provide information. And certainly our intervention handbooks provide a lot of information. We even direct them to websites for information. In fact, when we did the first study, in the information handbook on dementia, we listed all the services for dementia patients in each area, in Timmins and in Lethbridge. Yeah. But it's then using the service that has to become the goal. And, how do you set the stage for you to get there? Okay, so this is a feasibility study, the first study we did, and located in Ontario and Alberta, and involving 66 caregivers distributed across Alzheimer's, Parkinson, and stroke, and then randomly assigned to service as usual or the intervention program. And there was a group facilitator, training and supervision. And in the location was Timmins, in Lethbridge. Timmins, we had a nurse, a very experienced nurse who facilitated the groups. And in Lethbridge, we had a social worker. And there were 10 facilitated sessions. These were weekly online video conferencing meetings of 1 hour duration. But then it was followed by no facilitator, and the groups continued to meet for 10 more weeks. And the evaluation was at baseline, 3 months, 6-month follow-up. This is what the website looked like then. So it's password protected, which means you must be registered to the website. You cannot enter it at any time unless you're registered. Who registers you? Well, the admin person. Okay. And so you have a username and your password. Then this is what the website looked like at that time. You'll see a difference from what we do now. So under caregiver resources, that's where we had all of the information handbooks. So on that study, we had one for dementia, one for Parkinson, one for stroke. Message mail, we had an embedded email system so that the users in each group had their email address listed, and all they had to do was click, write a message, send, all within the website. The online discussion was an online chat forum, and that was just type in whatever you want and keep the conversation going between sessions. Okay. Caregiving strategies. At that time, we had some videos and we had some animations dealing with critical issues in the care of people with neurodegenerative disease. And then me and my group was the video conferencing. So they'd click there, and then there was a schedule, they clicked the time of their meeting, and they entered. This is what it looked like. Now, look carefully. At that time, we did not have group video conferencing software. It wasn't available. So we had one active window, and that's the social work, Rini Kleiman's in the middle. That was the active window. If the others wanted to speak, they had to click speak bubble. And then she would bring them into the window. I thought this was going to be disastrous for group, you know, that you have to wait your turn and so on. Wasn't the case. I have to tell you this story. After the group had been, in each of these areas, been meeting for maybe 4 or 5 sessions, they wanted to meet in person in Timmins. So they asked the facilitator. So she arranged, they met at a restaurant, and they all arrived there. They all hugged each other. They'd never met in person. They'd only met in this kludgy, one active window, but they were totally bonded, and immediately started telling stories about what a lifesaver this was, that they could connect with each other and really get the kind of support they were needing and longing for. So it turned out that this unusual video conferencing, group video conferencing, actually worked reasonably well. Okay, here are the results. Now I'm just looking at the ones who were in the video conferencing. I'll show you the differences between the two groups. But here's the 33. Average age was 67, so they're primarily spouses. Number of years caregiving, 3.5. Gender, 64 women and men. That's usually the distribution, even more women, usually more women as caregivers. 27 spouses, 6 children, 80% high school, and their income was not a lot, but maybe 12 years ago that was substantial, I don't know, but below 40,000 for most of them. So then we looked at, because we were able to look at how often they went to these various links, okay? So you see by color, the chat link was used a bit. Video conferencing, of course, that was all preset, so that was represented that. And then the email, they used quite a bit, but notice the handbooks, hardly at all. So what does this tell us? This tells us that if you just give them information, it sits there. It's dead. It needs to be discussed. Why? Because the internet is full of information, fabulous websites. I mean, go to Canadian Alzheimer's, American Alzheimer's, Heart and Stroke Foundation, all these excellent information. But what we don't know is How do people understand the information? How do they apply it to themselves? Does it have an effect? Total unknowns. However, we live in an environment in terms of the internet now, especially in the healthcare, is get the information out there. This is a biggie, okay? Information, knowledge transfer, that's a biggie. Just get the information out there. It's going to make a big difference. It's not. It's not. It's good, absolutely, and there will be people who can really make good use of it, but I would say the large proportion won't. The other thing is who accesses the information. We have no idea. We have no idea. So it could be the people who need it most are not accessing it. So it's something to think about in terms of the information that we do provide to clients, whether it's caregivers or patients with chronic disease. Now here are the differences between the two groups. This is the control and the computer group. And so the ADL distress and the ADL distress at follow-up, okay? So what do you see? The control group, the distress increased, and for the computer group, the distress decreased. Okay? So this is distress related to ADL and IADL. Okay, here's what they told us. It was extremely positive experience for me. I don't know that I would learn so much. I have opened up to total strangers in the group. I can't do that with friends or family because they won't hear it because it's too depressing and they have their own problems. You don't get as stressed out as much. Now the one about I don't discuss with friends or family because they don't want to hear it. You hear that a lot from caregivers, a lot. Okay, so that was the first study. I'll pause for a bit. Any questions or anything with that before I go to the next one? Anything from your folks there?
I'm going to just ask,
Not yet.
yes? It's Barbara Colley. Self-care in this particular study was related to the care of the caregiver. It wasn't related to the person receiving the care and enhancing their ability to self-care. This was all about caregivers.
That's right. For these particular ones, especially the dementia ones, we didn't get into that. We certainly could have gotten into it with the stroke and Parkinson's,
Yes.
for sure.
Okay.
But now, and that's my next talk, not this one, the next one, is about self-care of chronic disease. So that's what our most recent work. And the platform now supports that as well.
Oh, good. All right.
So I'll be talking about that.
Terrific. Thank you.
Okay, I'm just briefly going to show you our, yes.
Sorry, I did have one question.
Okay.
From Shauna, who did join us. So Shauna is a student, MNNP student at U of T, and an RN. And her question is, were the differences between groups significant, statistically significant?
Yes. Okay, I'm going to talk about this study because we were interested in looking at how a program like CBT, which is the best supported intervention program for depression, psychotherapeutic, how would it do in a internet environment, and particularly group. We already know that CBT one-on-one in internet works well, and there are a number of programs available. In fact, you can sign up for doing online CBT as a patient. Yeah, and I haven't looked at this for a while, but there are several organizations in England where they screen the facilitators who are all well trained in CBT, and they've set up the platform for them to deliver it. So, but we wanted to look in particular in group. So this is what we went through. We screened 31 older adults. And it was for older adults with diagnosis of depression or anxiety. We did the skid, doesn't matter. Basically, it was really to reliably see whether they qualified for the diagnosis. 18 met. Each patient had the option of selecting either online or the clinic-based, and we did that because we thought, let's go for the people who already have some comfort in terms of using technology. There were 13 weekly sessions, and the intervention in both formats were facilitated by someone trained in CBT. So this is if you know CBT, this is the typical protocol. And it was followed online as it was face-to-face. We filmed the face-to-face, and then we archived the online sessions. Okay. So the data is based on 2 online groups and 2 clinic-based groups. Patients per group varied from 4 to 6, and the online video conferencing sessions were archived. Now, the software we used here allowed all members to be able to see, hear each other in a group online. And we'll show you what that looks like later. As I said, the clinic-based sessions were filmed, and they completed the Beck Depression Inventory pre-post. So, the aim of the data analysis, and this is what we've replicated across all our studies. Examine the within-between group response to BDI. This is the Beck Depression Inventory. Examine a reliable adherence to CBT. In other words, did it look the same face-to-face and online? Examine the discussion themes by phase of therapy within each format, and then describe the participants' perceptions of using technology to access a healthcare service. Of the 18 participants, 10 chose the clinic-based, 8 chose the online. 72% were female, average age 50 years, and the face-to-face were slightly older. 3 participants withdrew, 1 from the clinic-based, 2 from video conferencing for non-clinical reasons. And this is the treatment reliability and validity. Now, for CBT, there's actually a standardized coding system for checking to see whether it's adhering to protocol. So it's all preset, the codes, not open coding. And so 2 research assistants applied the coding system, and we had between 85 and 90% agreement between coder agreement. And subsequently, they coded 2 early, 2 middle, 2 late sessions in each group format, and showed reliable adherence to intervention protocol. Okay. Now you could say, why bother? Well, if you don't do it, you don't know. Okay. All you do know is face-to-face, yeah, but you don't know about online. And I think this is the missing step in most online programs, is that we do not look at whether or not they adhere to the intervention strategies in the same way as they do face-to-face. So we looked at the BDI, and they were equivalent for both groups. 60% improved, 20% showed no change, and 20% moved from moderate to severe. Okay, and it was the same in both groups. Okay, now this is a very small sample. The session themes, they were identical in both groups, and not surprising: depression, low self-esteem, relationships and stress, and managing work-related stress. Here are the feedback from the patients. Enjoying the group. I think that I'm slowly getting over the technology thing. I felt it was more like I was talking to other people rather than these images on a computer screen. And everyone has to get past that stage, including the clinicians. Here's the therapist. CBT online form was initially challenging for the therapists. Engaging with images of patients on the screen rather than full person view of face and face-to-face required a shift in engagement working strategies. She had a great struggle making that shift. And she wouldn't mind my telling you, she was supervised, we guided her weekly. However, there was on top of it technical glitches. We were using a new video conferencing software and it wasn't working well for us. However, following the first online intervention group, by the second one, she was totally comfortable working online. Yeah. But it really meant that she had to feel as confident and as competent in the online environment as she did face-to-face. And that's that one.
Did anybody in the online speak of the ability to sort of read nonverbal language? Did anybody in the online
Talk about that? The absence?
Missing those sort of nonverbal cues?
No. I think the clinician.
I was going to say,
Yeah,
probably
well,
the therapist.
Yeah. Yeah, you can imagine having full body and then all you see is face.
Yeah.
It's quite a change.
Mm-hmm.
Yeah. Yeah. Okay. No questions? Wonderful. Okay, so now I'm going to take you to where we are now. Okay. So this is, I would say, the last 5 years we have focused on programs for people with chronic disease. And we have a new website and reprogrammed it, did a lot of things. So here we go. These stats you're probably familiar with. I found them overwhelming, actually, initially when I got into this, because I sure didn't know much about chronic disease or its care. But the prevalence is huge over the age of 65, okay? 80% have a chronic disease. Of these, 30% have 3 or more. So the comorbidity is a huge challenge, both in terms of healthcare, medical care, and self-care. 60% of all hospitalizations visit hospital emergency department due to exacerbations of chronic disease. 60 to 80% of general medical costs are related to care of persons with chronic disease. But this is all age groups, not just aging. The most prevalent chronic conditions, and this is adults, cardiovascular, stroke, type 2 diabetes, COPD, and cognitive impairment, MCI, and dementia.
MCI.
Oh, mild cognitive impairment, sorry. So, with an increasingly large and aging population, these are going to become, obviously, huge issues.
So we sort of talking about the mildly confused.
Sorry?
We sort of talking about the mildly confused. Mildly confused was the terminology's changed.
Oh, yeah, no, mild cognitive impairment. Oh, there are whole programs now in terms of dealing with that, yeah. Okay, so typically what's provided are rehab programs. And I'd have to say in large centers, you know, like Toronto, large cities, where in fact you have quite a comprehensive rehab program. And think of here, Toronto Rehab, TRI, you know, have these programs
Right.
for, as you probably know. And the focus is on diet, exercise, smoking cessation, alcohol control, and social engagement, pretty much. I would say increasingly, due to empirical evidence, exercise is really becoming top of the list for all managing all of these chronic diseases. There are also training programs, and these have to do more with cognitive function. So there are memory training, executive function training, real-world cognitive applications, and mindfulness training. As I said, those would be sort of more for MCI and early stages of dementia. Now, here are the challenges to the healthcare system. Fewer than 30% of patients with chronic disease, physical or cognitive, are referred to rehab remedial intervention programs. Well, it's understandable. They simply aren't available.
Mm-hmm.
You know, if you live in a small town or village or rural area, you know, or you'd have to travel great distances to get to them. So we know very little about the rehabilitation efforts of 70% of those who are not referred or don't have access, okay? So think of a small town, somebody has been diagnosed with cardiovascular disease, maybe it's had an event, and so they recover from that, they're put on meds. They might be given some information about lifestyle. They might say, hey, especially if they're overweight, you might think of your diet, exercise, might. Okay, but I assure you the biggest emphasis is going to be on meds, and so it should be.
Mm-hmm.
But if you discount the other, these are going to be the repeaters who are going to be coming to their GPs repeatedly, they're going to be going to emerge, and they're going to have subsequent events. Then those who are referred, 34% fail to complete the programs. Of the completers, 50% fail to maintain the program at home. And we know very little as to why. So, this was our project question. This is our most recent study we're just finishing. How do clinicians and patients respond to using technology to deliver, receive evidence-based intervention programs focused on effective self-management of chronic disease? Aims use technology to reliably transition in-clinic evidence-based intervention programs to in-home delivery. So I'm still at the repeating myself over and over. That's what we've been trying to do from day one. Now this with a specific focus on chronic disease. So the website platform, which we are going to show you. We have online training of clinicians. This is totally new. I did not have it in any previous versions of the website. And the reason for this is these particular programs, okay, require the clinician to implement them reliably, because we only know they work on the basis of if you do it this particular way. And so the training has a intervention training manual online, which is accessed by the clinician. And in this study, we had 3. One was the cardiovascular disease. One was a manual for managing chronic disease, cardiovascular was the population. One was for MCI, and it was a cognitive training model. And one was for older adults who had complained about memory issues, undiagnosed. And it had to do with real-world strategies. In other words, how do you cope with slipping memory? Then they, after they read the manual, studied the manual, and remember, these are trained clinicians, experienced clinicians. They then met with the expert on the model online prior to starting the intervention, and then after 2 or 3 sessions they met with them again. So that was the training, okay? The intervention manual and 2 meetings. The patients had access to the password-protected website. They could review the disease-specific content, they joined the video conference sessions, and they completed the evaluation questionnaires. all online. And we now have a module totally focused on healthy lifestyle behaviors. And we now promote it for caregivers as well. And it's evidence-based. So all the information is based on studies. And this is what the website now looks like. Couldn't be simpler. So the intervention programs, this is for the video conferencing. So they click there, and one of you is going to be doing it. I brought a, where's my computer? Right there. And we're going to ask Diane to join. So basically, the clinician pre-schedules the meeting. It's a specific time, and gets everybody's agreement to meet at that time. And they just click, and they're entered into the video conferencing. Then on the right are resources. Upper right, glasses so I can read it myself. So they're information handbooks. So what happens is when a patient is registered, they're given permissions to access certain materials. Okay? So when they go to handbook, they go to the handbook that's specific to them. Then there's the tech training manual. Again, the clinician has a tech training manual. The patient user has a separate one, and there is a admin manual. And they're all simplified as you go. So the admin is the most complex, clinician's the next, and the user is the simplest. Helpful URLs is what I talked about earlier. We direct them to go to specific websites that have very good information for that particular disease. And then the evaluation questionnaires. And the evaluation questionnaires are specific to the intervention. In other words, what does the intervention target to change? And now we're going to measure it. So they complete them pre, post, and we can then take a look at whether they improved. So we continue to generate evidence as we go. The health and well-being, this is for everybody. Disease prevention management, physical activity, healthy eating, stress management, and cognitive activity. And then the intervention training, only the clinicians see this. And so there's a training manual, supervision consultation resources, and intervention training materials. Okay? So that's the now, managing chronic disease. This just gives you an idea of the content of an information handbook, okay? Living with a chronic disease. For chronic disease in rheumatoid. Oh no, this is the intervention manual, sorry. So what we did there is we provided some information about the 4 main chronic diseases that we cover, which I listed earlier, okay? Cardiovascular, diabetes, stroke, and COPD. Then self-management of chronic disease, barriers to managing a chronic disease. Like for caregivers, it's a biggie with these folks. Because remember I said earlier, why don't people adopt rehab behaviors? Why do they drop out of rehab programs? Why don't they maintain rehab programs at home? Okay, we don't know. We know a little bit about medication. They're often very bad at taking their meds. And that often has to do with confusion as to time, dose, and so on. I think these blister packs that the druggists will do, that helps. But some need reminders, side effects, comorbidities. I mean, there are all kinds of things going on. There's some information on that, but hardly any information on anything else. Beginning information on depression, that depression often accompanies the chronic diseases, especially at diagnosis. And I'm sure there are many other barriers that we simply don't know about. And then the management of chronic disease. And with, it's actually very similar to the caregiver intervention model. In other words, people talk about their subjective experience of the disease, what it means to them. And the same disease means very different things to each person. You know, what was the reaction to the diagnosis? What's it like, you know, living with it now? And so they begin to talk about that. Some people talk about dying, life's finished. Others, denial. Just carry on their lives the way they did. So you can imagine with a diabetic, to carry on their lives the way they did, they're in deep trouble. So they're, you know, but it was so important to have them really talk about their experience, rather than talk at them. And so that's a similar model, because through that we began then to see what got in the way of their not adopting a rehab program. This is the information handbook, and this is all the disease handbooks are kind of modeled on this. Understanding the disease, emotional response to it, coping and support, rehabilitation, and adopting healthy lifestyle behaviors. And in each one, we do list the resources. Questionnaires. So when they go to the evaluation module, there'll be questionnaires that are specific to the intervention program. This is the HSQ, Health Status Questionnaire, highly standardized measure that we use in all our programs. And why? Well, it just has terrific normative data so that you can compare your sample to by age, by gender, disease category. I mean, it's really very useful. The other thing is you can get a short version, and you can get a physical health score and a kind of mental health score. And that's very useful in terms of tracking change, especially with these types of interventions. Now, this is what our video conferencing looks like. This is using Adobe Connect. This is our the software we've chosen. We've tried several, and we like this the best. It's a little more complex to set up, very robust, and it really works quite well. The other thing, if you notice, if you go down to the left-hand lower box, they can text during the meeting.
Mm-hmm.
So if somebody wants to enter, and this actually was quite useful if someone's audio wasn't working or video wasn't working. They could still. But also it allows another option for communication. You can also video stream. Let's say you want to show a video, you want to show PowerPoint, a PDF. You can show it during the meeting. It's uploaded, and you can share it, and it can be the point of the discussion. So that works quite well. Now we're going to demonstrate that in the second half. And how are we doing on time? Okay. Technically, training the clinicians. Okay. So, these are the clinicians' tasks, and this is going to be the challenge, because as clinicians, we vary in terms of our tech skills. I'll start with myself. I am not a techie. I've been doing this for 12 years, and I probably don't know much more today than I knew 12 years ago. I couldn't program anything, and I'm still all asking questions. So who do I rely on? Joanna.
I'm not a techie either. I just picked it up.
But over the years, I've had students from the computer science department here. My programmer, who thankfully I've had the same one for 12 years, he's been very patient with me, and so he answers the questions. But here, basically, a clinician, to operate this system, has to do these very basic things. They have to obtain and enter a username and password for each participant. They do access a digital copy of the tech training manual, so all the information is in the manual. They access all the website content and request support when needed for website navigation, which means they're available to provide tech support to the patients and caregivers. Okay? Does that sound a little scary? We think they can do it. I think we're at the level of development in terms of simplifying the technical aspects that I think they're really going to be able to do it with not needing a lot of support. This is the participants. So they supply username and password, and which means they can immediately access the website. They can look at, they also get a tech training manual. The clinician monitors the website navigation, provides support, and schedules the video conferencing meetings. The training manual, note, this is not for neophytes, okay? These are clinicians who are experienced, and they're going to learn a model that they already know a lot about. Okay. Okay, the intervention. Now, since this is all happening online, you don't have somebody coming in being assessed. Okay. Usually you're going to get a referral. Let's say if it's let's say cardiovascular, you're going to get a referral from either cardiovascular unit in your hospital or a GP who's concerned about someone, with the diagnosis who's not doing rehab. But you're going to meet this person online. And so they should have one face-to-face meeting with or more with each patient prior to joining the group. So they can deal with all the technical glitches, they can get to know the patient a little bit, they can orient the patient to the group and what to expect. Okay? Typically it's what you would do in a face-to-face environment, so you do it online. They schedule the meetings and they request the online completion of the evaluation questionnaires. Okay, so this would be the pre. Okay, so then we archived all the sessions and we analyzed them, and these are the group themes, none of which are surprising. What did these people with chronic disease tell us? The loss of ability, identity, and independence. For some patients, the diagnosis meant they were no longer the person they'd been prior to the diagnosis. And great difficulty accepting this perception. Mind you, it was an exaggerated perception, but nonetheless, that's what they were struggling with. Anger and frustration about their physical limitations. Some financial resources and transportation was an issue. Others, gradually they moved to acceptance and adjustment and the importance of social support, health issues, and healthy aging. Some of the stories, especially around changing diet, always converged on family. How do you change your diet if the family isn't changing their diet? Should you impose that on the family, that they should change their diet to accommodate you? And how to work that out was quite a struggle. The other was exercise. It was if a family member could exercise with them, if a friend could, it just made such a difference. Especially for people who've never exercised in their lives. And suddenly they're being asked to do 30 minutes of something every day. And it was really tough. And so the social support was a big issue. 3-month follow-up. And this is their response using technology. See the person helpful, face to a voice, great experience, didn't have to use a bus, which is hard for me. Great opportunity to learn about technology, so who knows, probably the technology made the difference, right? This is a new and very positive experience, easier to talk with a few people rather than a large group in rehab. So I think it's all the issue of trust, of bonding, and being able to provide mutual support in a group is what they were telling us. And that's that.
Growing distance kind of geographically close, that you could actually get to meet them, clinicians could have to meet them. I'm thinking that in home care, for example, we're right across the province. So running a program out of Toronto, somebody in London couldn't tap in.
But they met them online, didn't they?
They're all online.
They met online.
No,
Oh,
it was
yeah.
face to face.
Oh,
Yeah.
no, they
Just
never met in
face-to-face.
person.
Okay.
No, it was all online.
So that's
And it was
kind of-
very important that they meet one-on-one, online. Mhm. Especially in the absence of not meeting
Yeah.
in person.
Yeah.
So I probably missed something. They were meeting online. The clinician was in a video conferencing arena place, and the clients were at home.
Yeah. They were
And
sitting
so
in front
they
of.
just used their webcam.
That's right. They
That's
were
all.
sitting in front of the
Okay.
computer. They were
Got it.
seeing the whole screen,
Fair enough.
and they were going into with the video cam.
Right. got
Now,
it.
fortunately, most computers now have an embedded video cam, and
Yeah.
in our days, the past,
Yeah,
we
yeah.
had to get cameras, and and they had to be focused, and you had to click on the camera to get it to work, and then you had the audio.
That's right.
Now we can use earbuds and an embedded camera.
Yeah, perfect. Thank
Much
you.
easier. Hmm.
Terrific.
Any other questions?
None?
None? Okay, so I'm going to suggest we take about a 15-20 minute break. When we come back, Joanna's going to set it up so that she's going to set up a video conferencing session. She's going to, we'll have one of you use my computer. She'll give you a login, username, and password. She'll do the same with you, Diana. Diane or Diane?
Diane.
Diane, if you would like to participate. And so we'll send you the username and password. And then she'll schedule the meeting and you'll go to the schedule. But in the meantime, you'll be able to navigate the website and take a look at all the modules. Okay? Then we'll talk about how would you use the platform to present one of your programs, and we'll develop something here. Okay? Good. So we'll see you in about 15-20 minutes.
And we'll put a break thing up, and then they'll know when it comes down that we're
Oh,
ready.
so what do you want me to do?
Just down below, there's a PowerPoint that says break. You can just click on it. Raz can see it.
Oh, there we go. Just go over to
View show.
slideshow. Go to slideshow. And then over to here. Yep. There it is.
And Diane said, yes, just send along the information. She's happy
Okay.
to do so.
Good. So go ahead.
No one else came.
Yeah.
They're all online? Okay.
Thank you, Raz.
No
I'm so
problem.
sorry.
That's okay. I waited downstairs when no one came, so I just left. We're all good.
Yes.
All right. More water for us. I do have to leave though. So can I help you with anything else here?
We're good.
Are you sure? You want me to collect up any the stuff? Or?
So we'll set up
No.
this.
Okay. Anything I can do downstairs, Susan?
Mhm.
Anything downstairs I can help
No,
you with? Or?
I've got my keys.
You're good? Okay.
So you can walk up and I'm
Okay. All right.
Okay.
It should be hardwired.
I didn't do it. No.
It's a major.
I was just so crazy busy today. I know.
ED.
So that means
Carol would suggest two people and you get sort of forward screening. Bingo.
Yes. Yeah.
VP.
So what can I do for you
Oh boy.
right now? Will you be able to get a signature?
I'm going to be the
I don't know if I can make it.
mildly
For,
cognitively
you want me to do it right now?
impaired.
I'm just running down.
Are you sure?
Okay.
Yeah, so we had a little problem with the website this afternoon too.
Which one?
I can't tell you, but it's not far, and you turn a corner,
Nice,
and you'll
because
see it.
We were down to 97 participants.
and yes.
And 30 for the poster competition.
When you say down to, do you mean we had
Regist-
that much room?
We only had 97 for spots left. And I said, that's not possible. I talked to the lady from Live Fast. I suggested that she register the second person to not give away any additional spots.
I mean, we're in the early stages yet.
And,
I think
no problem.
technology can
And
be.
she said, no problem. So she said, I can register. And she registered. I see that it's down to 101. And it's down to like 97. So I was like, this is weird, right?
Did 4 people
No.
register at the same time?
I don't know because I don't have
I
access to.
can look for you.
But here's the thing. And the student registrations, the ones that require a code, which I haven't sent out, start dropping to 30. And I called Anthony. I said, excuse me.
Oh my goodness.
Reza,
Mm-hmm.
what is the web address?
Which one?
Mine.
Oh, for the e-care?
Yeah.
I'll send it to you right now.
You're like me.
Pretty bad.
Oh, that's cute.
I can never remember ours. I was up with typing a search, TV, East presence, aging, and it always comes up, but I can never remember what it was. Oh, Joanna, Diane is ready.
Okay, that's great. So
Bookmark.
what I'll do.
And can I send it to her via chat?
Yep. So I was actually going to make a slide with the website and send her login information that way. You can send it via chat, or she can
what
look
is
at
the
the.
web address?
What just
It
happened?
is. So I'm. Does it have anything to do with this?
No, I mean all my
So
people
it's
just.
e-care, CFO.
Oh, maybe they all went to take a break. I don't have anybody in the thing anymore.
eCare CFO.
-cfm.com.
Right.
Oh, here it's back.
Okay, Susan, if I get to it tomorrow, I'll run and get Barry's signature and bring it to you.
Are you
Okay.
connected to the internet?
I'll need yours too.
Oh, I should. Wow.
Yeah, well, I'll have to be
That's
here.
the problem. Why am I not?
Well,
Do
if
you want me
you're not, if
to-
it doesn't work out, you can come tomorrow. That's like, are you planning to come Friday?
It's tomorrow or Friday.
Oh, I see.
Yeah.
Did you already have Friday in mind rather than tomorrow?
No, I just.
How do I
I
get
need to just
internet
send it from my computer.
access?
I can do it here.
I need to just send
Can
it
you
from my
do it?
computer and do a bunch of work. Because I haven't felt like I've been getting anything done here. So I'm
get
just
by?
running
Yeah.
around in every direction. I know. And I just I'm behind with stuff for Sander and behind with stuff for TDN. I just gotta sit at home and be getting
One
that.
to the left,
Okay, we just gotta
one to
focus
the
and
right.
get this done. So
Yep.
maybe tomorrow,
Click on
maybe
that.
Oh.
Friday.
You need to
I might need
connect
to do
to
both
your
days, to be
TV
honest with you. So,
I don't know if you have your Tour ID, but I can.
Okay.
Like I usually
Well,
know.
will Nina be here?
Username
Why not just do
For
the
you
checks
too,
right
so I
now?
can just.
No, I don't.
I'll do that. The invoices are there.
Hmm?
The invoices are there.
Yes, they are.
So I'll just write them right now.
Are you okay with
Yeah,
that?
yeah, Yeah, we got our check.
We did?
The 25 grand, yeah.
It did come in. Oh, I didn't.
Yeah.
Oh, yes, you mentioned it when I was there, the
So-
letter.
Yeah, so the
Right.
buffer is
My
there.
computer.
Yeah.
Nothing
so-
we can use the money in the account for whatever, and then put 25,000 for that in simply accounting.
Yes.
Because
It
simply
should be
accounting
there.
doesn't know.
Yeah, so
What we
it
did,
shows
right?
up here. It's
Oh.
Well, it has everything
Yeah.
except the prevalence study deposits.
No, I know.
Oh, okay.
Okay, I'll take care of that right now, so then we don't have to worry.
Okay.
All right? Okay, bye.
Bye, Reza. Thank you. All right, so tell me what I need for Diane.
okay. So I'm putting it on the slide here. Can she still see these slides?
Oh. Right.
That's fine.
Did you get it?
No. What happened here?
Do you need? I can come here. I've forgotten your name. Is it
Barbara.
Okay. That's
Yeah,
fine.
do you need the full name?
No, that's okay.
Does that say Mary and Mary?
Yeah. So that will be the username and the password to get into eCare. So I created a fake account
Oh, here we are. Oh.
for the purposes of today.
She says I'm in.
She's in. Great. So you can tell her to hang tight and we'll do the demonstration.
So, you're going to log in once she gives it to you. So log in username, password.
All right.
I'm not gonna reach over to you.
Oh, good. Okay.
There you go. I don't know.
Now Valerie's asking, are you using PVVC, no, PCVC for support groups or video conferencing?
Video conferencing.
Type it in case she's not at a computer.
I want to get rid of that bookmark.
I know. How do you do that?
Now here's my next question. If the other people online do have access to webcams, would
Yes.
you like them to join in? Or would you prefer that
Sure.
you just have the two and the others watch the?
My only concern is that then I would have to create accounts for them. So if anybody really wants to, I'm happy to do that. So you can ask if anyone else wants an opportunity.
Oh, wow.
How do I get rid of this sidebar with my bookmarks?
I'll be right there. You know what? They can probably all log in on these accounts as well.
How are you going to admit them if they're not in separate? How to get rid of this?
I mean, if they use the same accounts, then we won't know. We won't.
Yeah, I'm afraid if they do that, then actually that's a bad idea.
Okay.
Yeah, they're separate.
I'll say let us know.
So normally when you click this,
Edit. Edit.
you don't want to edit the bookmarks themselves, you just want to make it.
But just go out and then we'll go back in.
So do you go back to?
Just then get rid of this and then I'll just go back to Safari.
I'm not surprised. Do you have Chrome on your computer?
Yeah, I hope so. Prefer Chrome?
Sometimes go to the website. That's if possible.
Is-
Not there. Let's use Safari.
You have two usernames
Yes.
for me?
So,
Oh, I think
that's
that
supposed to say
password.
password. Yes.
I thought
Thank
so.
you, thank you.
That's okay. Just
Password.
so.
Okay. Yeah.
And Joanne,
Yes.
when they come back, even if they're not part of the demo, they'll be watching
They'll be
with
able
you
to see.
on the slide.
That's
so
right.
they'll see it in the webcast.
So my password is password.
That's right.
Okay, gotcha.
And cap lock. Make sure it's very case sensitive, so make sure there's no caps on.
Uppercase.
That's right. So make sure it's lowercase. What I'm gonna do, I'm actually gonna give you headphones.
Okay, I'm just making sure that they know.
So
Okay.
there's a microphone built into these headphones. And you can put them on that side.
She's gone?
Yeah.
Mm.
I don't know if anything can hear me.
Yeah. The other thing is she could have arrived at her destination, shut down, and was going to try to get back on again.
Oh,
That could be.
She's on her way somewhere.
Because she was en route. I didn't want to
Gotcha.
miss the opening. Sorry, what do I?
So I think it puts them on this
Oh,
one, so
there,
we'll plug
that
them
is.
in.
Okay. And then these go in here?
Yeah.
Okay, so the
This one's
microphone?
right here. So this is actually a microphone. This is a speaker.
Oh, there it is. Okay.
So then you can hear the audio
Okay,
in
great.
person, but you'll also be able to hear it through the song
Okay,
if all goes well.
it's all good.
Oh, it keeps coming back up.
Yeah. Well, I can ignore it if you want.
Oh,
Oh, gosh.
that'll be better.
There we go. So right now, there's no audio, right? Okay.
So just make
So
sure.
you're going to put in
I'm
username
gonna be
and password.
in March. And my password is password.
And don't hit enter.
And you do have to click.
I have to submit?
Yeah.
Okay.
Whoops, it won't work with just return. And there's the website.
Excellent.
Or we can get it to take over the whole screen.
Mm. Mm. We can't get it to be big.
And we'd like it just to take the whole screen. Oh, it's also missing. Oh,
My
you-
little
Well,
quarter
so
is
she has
missing.
yeah, because
Oh.
you're not a clinician on this one, you're a caregiver. So
Okay.
Oh.
However,
This is what
you can start visiting stuff.
Good.
There's the Mention Handbook. Okay. You just
All
there.
right. Excellent.
You just wait till it goes across. It's loading, and then you can scroll through.
That's amazing. Oh. Now, did you spend much time on the font size and
I had somebody who does all the formatting for
all
me.
that?
Yeah.
Mm-hmm. Oh, great.
But
Now,
then
can you
we
click
can
on this and go right to it, or do you have to?
I don't think
No,
you
it's not
can.
like-
You can't.
You can't.
No. We
So-
used to in the previous versions. I forget.
I like how clean it is.
So there it is. It just begins with the.
Hmm.
And then to go to the tech manual, you can just.
Then to get out of it, you just go.
You should be able to just.
Is there a return or
caring for others
an
and
error?
then caring for me. So there's two intervention programs.
Actually,
Caring
you
for
can
others
go
is
to
the
the
caregiver.
home page. Where is it? Here it is.
Chronic distance, yeah.
Oh, I see it.
They used to be
Under the
two
e-care.
separate websites, and then we decided just to put them together because it's
Yeah. So then you can go to tech manual. I don't think there's anything in helpful tools, but tech manual. And then you can go down and see all these topics down
Can I
here.
go into the intervention
No,
programs?
well, that's the video conferencing.
Oh, okay.
You
We'll
go
go
there
there,
and.
Once we get
once we
there.
get
Oh, I
going.
like this though. Maybe I can go into.
Yep, just go down.
Yeah.
And then you can go to any one of those.
Hmm.
After the announcement break is over.
yeah.
So how many are online now?
There were 6, and one arrived at her destination, but she hasn't been able to come back yet.
Oh, okay.
So there's 5.
Okay.
So everybody's here that registered.
Oh, good. 8.
Mm-hmm.
Mhm. A friend of mine who's a psychoanalyst wanted to come. I should have told her to come.
Yes. Yes.
Or even online.
Exactly. Just so you all know, I don't have a way to turn the audio off separate from the camera.
Mm-hmm.
So all during our break will be part of the.
Okay.
The video, the recording.
Right.
Okay.
That's fine. Do you want me to bring up another chair?
No, no.
No? Okay.
I'm fine back here actually.
Oh, okay.
I can just speak from here because basically what we're going to do is do this little demo of the video conferencing. But also they now can surf. Did Diane get connected?
Yep. She said I'm in, and I just told her to hang
so
tight.
she can surf the website and just take a look at what's there. Then when everybody's back, we'll have the video meeting. And then they can see what it's like. It'll show up on the screen.
Mm-hmm.
And yeah, so we're good. Sorry?
Oh no.
Raza.
Oh, you should tell her you're going outside. I only asked them to keep it open until 7 because I didn't anticipate once people arrived having to go back and forth.
My
Oh, that's
meter.
too bad.
I was afraid I was going to parking ticket, so I had to feed the last hour.
Sorry, B. Okay.
Okay.
So Diane says I'm logged in, but video conferencing does not connect yet. May not have started on your end.
That's
And I'm
right.
going to say that.
Smart girl. Oh, I went and pressed something.
So if everybody's back,
What did I do?
oh,
I got out of it somehow.
yes.
I don't know why I did that. I didn't mean to.
Any one of these icons here? No.
I can come over if you need. Okay.
That's weird.
Do you need a hand?
Is there an icon that I'm? I can't go too far because I'm hooked.
There.
Oh, your headphones.
No, it's not dot, that's what's wrong. Dash.
We recently changed the consolidated.
And that should do it.
Oh.
Oh my God. So who am I going to hear? Diane and you?
And you. You're
And
gonna be
myself.
all- Yeah, you're gonna see each other.
So you're still here.
You're gonna be in video conferencing mode, and we're gonna watch you.
We don't
Thank
have to
you.
do it for very long.
Thank you.
Okay.
I'll try not to press stuff.
That's okay.
Okay.
So you can tell Diane that you're, are you in?
Okay, so Diane she said that she's logged into eCare, is that correct?
Yep.
Okay, so for anybody else, this is the URL to get into the website. In order for other people to participate, I'd be happy to create another kind of mock account, but for just the purposes of trying to have as few difficulties as possible, we'll leave it with Diane and Barbara to demo right now. But as I said, you can always type a message and we can create another account. But so the way that the video conference itself works, so very simply, so I'm the clinician, let's say for example. I create a meeting, and I can go through that if people are interested, but I create a meeting in Adobe Connect. The meeting gets programmed, however, into eCare. So Barbara and Diane are able to log in, and the way that people connect, the way that participants connect to the eCare is from the home page, the green module where it says Intervention Programs. It says click here for the schedule. So if Diane and Barbara can click here, you should be brought to a page with a calendar. So there is a group that starts today at 6 p.m.
Called workshop.
It's called Workshop, 22nd April. And don't click on it yet, because I have to enter, because I'm the clinician, I have to enter the meeting first. Okay? That's part of the security, so I have to allow people in, and in order to do that, I have to be logged in first myself. So you can see my screen. It's very important that you click allow. That will just allow your webcam and your microphone to start sharing.
Have to find allow.
Okay, so I'm logged in now, so that's great. So now, if Barbara and Diane want to go back to the calendar, do you see where it says Workshop 22nd April?
Yes.
So you can click on that.
Okay.
And are you brought to, does anything pop up for you? Okay, so what should pop up now is it should say type in your username. So type in a name. So you can go ahead and type in either Barbara or you can type in Mark, who's your kind of pseudonym for today.
I'll do Mark.
Okay. And then you can go ahead.
Enter. Oh, enter. Okay.
And hopefully Diane's okay.
Good.
All right, so you can see on the screen there that Diane and Mark, who are both guests, want to enter. So I'm going to allow Diane to enter and Mark, who's our other guest, to enter.
So she's allowing you to enter now.
Great.
Okay.
Okay.
I'm going to connect my audio. Can you hear?
Very good. Very good.
Okay, great. So I'm going to now enable webcam for both participants. So I've been added twice. So now if Barbara and Diane,
Did you want me to turn the speakers off so you don't have an echo?
is that possible?
Yes.
Yeah, that'd be a good idea.
Yes, it is entirely possible.
Okay. So for Barbara and Diane, do you see a webcam in the upper right-hand corner of your screen? Do you see that yet?
Upper right-hand
In the
corner.
very top, in the top
Oh, where
toolbar.
it start? It says start?
Yeah, so you need to
Yeah.
click on Start Webcam. And same for Diane. If you don't see webcam, there is in the top bar, there's a little diagram of a webcam. And it does need to be green.
Doesn't seem to be.
Oh, there's Diane.
Yes.
Hi, Diane.
Okay, and let's see.
Where's that looks like it's the webcam, but it's not. Should I try double click? My little webcam won't work.
I wonder if it's been activated in.
Maybe if I'd done Barbara.
Do you want me to come over?
No, I wonder if it has
Oh.
to do with the webcam on my particular, on this,
Computer?
yeah. It's a, Apple Air.
Set to stay
That says
before
listen
you.
only. It's funny that that would.
Do you want me to come over and see? This was my apprehension that if the webcam's not
On this particular computer.
so
We were trying there, is that right?
yeah, from here is also fine. So
There,
I
allow.
click allow.
There it is.
Okay.
Oh,
And you have
Good.
to click start sharing. So I'm gonna click start sharing, okay?
go ahead. Now I can
Okay.
fix it.
Now, if you move them all to center screen, we'll see you all.
Okay. So Diane is back. I'm going to make it full screen now, and Diane should be joining us any minute now. So the first session with participants sometimes looks a little bit like this. The first 15 or 20 minutes, it's just getting everybody familiar with logging in and getting their webcam set up. So this is pretty usual. After the first session, though, it's okay. Diane is logged in twice.
Oh,
Okay, so Diane, can she hear us?
Yep.
So Diane, if it's possible, I think you have two windows open, and it works better actually if you close one of them. And I'm doing the same thing
Diane 1 and Diane 2.
here. Yeah, there's sometimes a bit of feedback. Can you
One-
hear through the headphones?
Yes, I can hear,
Okay.
but I can also hear you.
Yeah.
And there's a delay, but
Oh, yeah, that's okay.
I can hear you perfectly.
Is Diane saying anything?
Not yet, it's not.
had her and lost her?
Yeah.
Well, she's on the other website, so she's probably not even reading all
Oh,
my little texts on the webcast site in
Oh,
the other
right.
window.
I can put a message here for her too.
Yeah.
Although she should hear us, no?
Yep. Unless when she goes to the other window, the audio doesn't. Unless she doesn't have the other window still open.
Mm. So everything's been enabled for her.
Maybe give her a little chat and
Yep.
see if that helps.
Oh, there she is.
There.
Oh, she said I was in, but it booted me out when I downloaded Adobe Connect.
Oh, all right.
Right.
That's generally the first session. So Diane, can you say something? Okay, so we can't hear you yet.
it's your, tell her to click the audio, the microphone, whatever.
The microphone, so everything's been...
No, she needs to click the
Oh.
microphone.
So Diane, is there a way in the top toolbar you should see an image of a microphone? Just make sure it's not on mute and make sure you allow your microphone.
Or tell her to go to the audio icon and
Or you
make sure
can go-
that it's on.
Okay. So Diane, there is an audio icon as well. It says audio. It's in the top toolbar.
Oh,
Jeez.
Oh, is she...
Can you hear yourself?
Can I hear myself?
It's like you're gone, and it's just weird.
So this was my concern, is
Okay.
that we have to make sure all the software is up to date and installed. So sometimes it does take a few minutes for this to get done. This will be the clinician's job to help everybody acclimate to the online environment. Diane, can you hear? Oh, she's gone.
And can I increase the sound of your voice?
You can.
Yes,
So you
and
manage
with
that
the
from the
audio icon.
volume. It's actually on the volume on your computer. You can probably manage that.
So
Okay.
go to the icon.
Here it is. I could do this one.
Yep.
Mm.
There you are.
Perfect.
Okay.
That's because this is a clever computer, not all of them have it there. Usually you've got to go to the icon.
And go up, yeah.
So what I'll do.
Yeah, it's quite nice.
What I'll do for interest's sake is hopefully Diane can log in soon, but I'll show you some of the features in the meantime so we can make it full screen. And this is what we recommend during the session if it's just discussion. So we tell everybody to go and to click the arrows and it'll make us full screen. It's just easier to see people. However, when we're presenting some of the written materials or we want to show, for example, a whiteboard, we do ask people to minimize the screen. And that allows us then to share, for example, a whiteboard. So I'm able, because I am leading the group, I have permissions. Oh, Diane's back. So you see this is a security feature, so I have to allow every single guest to enter the room. So I've allowed Diane to enter the room again. So I can type here on the screen, and you'll see it when I click, so that's very small. That can be adjusted though. So I can type on the screen. I can also, I can draw pictures, but I'm not a very good drawer, so I might not do that. But so this does come in handy if you want to, for example, somebody's talking about the plan of action that they're going to make. They're going to write out goals, so we can also be writing it out on the screen and help people follow along with what's going on. That's a very common feature. And then there's also different pods. So I can, one very cool thing that I think is very neat is we can make a poll. So I can ask a question. Can everybody see that? So I can say, for example, any multiple choice questions. So if it's something very practical, like scheduling a meeting date, I can say, pick the day and the time that's best suitable for you. And I can open it up to the whole group. And everybody can vote, all the participants. You can also ask other questions. Of course, you don't want to ask anything necessarily that's too confidential, but other people won't be able to see what everyone else said. It's just the answer. It's not so-and-so said this. So you could ask some neat questions to the group if you wanted to do that. And then there's also, you can screen share. And I think the most important feature that Elsa mentioned before is definitely the chat box. It helps if anybody's having especially technical issues. So this is basically the most important features, and this is what it looks like when we're in a group. So Diane, I hope your audio is working. But it looks like this. It happens in real time, and sometimes Adobe.
Have earphones on, or?
Yeah, it does. We do suggest using headphones. A lot of headphones also have a microphone in them, but that's okay because we did put you on the spot and ask you to log in without going through the text, so that's okay. I'm glad at least your video is working. So it was
You have a
pretty.
large group, the pictures just get smaller for.
Pictures get a little bit smaller.
Right.
We generally,
You have 6 or 8.
yeah, we generally recommend having 6 people in an Adobe room. More than that,
It's too crowded.
a little bit crowded. The audio starts to lag a little bit more if there's more than 6 people. So 6 would really be an optimal size. But so participants from the eCare website, they just have to go to click here for schedule. They select the meeting, and they can log in. They just click here, and I'm going to close it because then I'll have 2 competing windows open. But it's very simple. So the clinician, do people want to see how a video meeting is set up in the first place? Okay, so we do have, as Elsa was saying, a cheat sheet or a guide sheet that we use, and that it's very step-by-step. I can actually pull it up right here. And it explains how to use it. So this would be for the clinician. So it's step-by-step. So you open up an internet browser, you log in, we provide a login, and then subsequent to then you'll have your login information, and you'll actually provide the login information for all the participants or the patients who will be in your group. But so you register different participants to eCare. That's very important because they only have access to the website once you've already made a profile for them. So you've approved them, which is a security feature. So to set up a meeting, what you do is you log into Adobe, and you're also given login information for that. But basically you walk through and you set the name of the meeting, you create a custom URL for each group, and you set the start time and the date for the meeting. And then what you do is, once the custom link has been created, you copy it back into eCare. So for example, I want to manage a video meeting, I want to schedule one. I come here, I know it's going to be today, and let's say it's with, who did I put here? It's for our workshop. It's going to start today, and I want it to start at 9 p.m., so I just schedule it here. I select my group, and these groups will already be made for you in the website, so you don't have to worry about any of that. Let's call it our test group, and let's call it workshop April. This will be actually copied and pasted from Adobe, and all you have to do is click schedule meeting, and it's there. It comes up here. Participants will be able, because they're members of the same group that I'm in, participants are able then to just click from their homepage. I'll take a question in a sec, and it appears right there. Yeah.
Valerie's asking, is eCare part of Adobe Connect or a separate program?
Yeah, so that's a good question. So they're 2 separate programs. What we do to make it easier, though, is that the clinician basically sets up a meeting in Adobe, and they paste it back into eCare. So for the clinician, it's 2 websites. For the patient, though, they only have to log into one website. They only have to log into eCare. They're able then through eCare to get to the Adobe meeting.
Do they have to install?
They
No.
do. Well, it will prompt you to install it. It's not a very long installation process. My understanding.
Install what? You have to install Flash.
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 Yeah. But
Yeah.
they do that before they ever
That's right.
get to us.
Right, okay,
Yeah.
that's how they do it.
Yeah,
Okay.
so it gets installed on their computers, and then they're just asked basically for a name when they log in. It's not a very complicated way then to get into the meeting. They
Mhm.
just enter their name, and I have to approve them to enter the meeting.
And was it the clinician that copies it into
That's
eCare?
right. So the clinician schedules the meeting once. For example, let's say it's going to be Wednesdays at 8 o'clock. I only have to create the meeting once in eCare. What happens is that when I create it, and this is all in the tech manual, so it's laid out very clearly, but do you see here it says one time, or I can select weekly, or I can select monthly. So if I want it to be every Wednesday at 8 o'clock, I just select weekly. You don't have to create the URL. If you think about it as a physical room, so think about it as this room. The meeting room does not cease to exist. The meeting room exists, but you enter it and you exit. So it's always there. The clinician has to be in it before participants come in because we have to allow it, but you don't need to do it every week. It actually is, you only have to do it once at the beginning of the group, and then it's accessible after that point. Even if you want to say one week you want to do it on a Thursday, the physical, well, the cyberspace, but the physical room already exists, so you don't have to recreate it. And the link from the eCare website works every week. You don't have to do that either. You just create it once. So that's been simplified. So hopefully it's very
Think of it
easy
like
to
you
use.
reserved a room,
Mhm.
physical room, and it's there for you, and then you go to your group room on the date and the time that's scheduled.
Right.
So this is what it looks like. I'm going to just clean this up a little bit. The other thing is that we can always get rid of these little boxes that come up. Because it's the same room from week to week, though, you'll still have access to materials that you created in the room the next week, because the physical room still exists, right? So it does take about 15 minutes to kind of make sure everything's okay, but that's only for the first group. We do find, and we found throughout the studies, that once people had done it 1 or 2 or 3 times, it was much more seamless. So technical difficulties obviously sometimes do happen, and that's mainly because internet connections sometimes either slow down or time out. There's not a ton we can do about that, so you need to have a little bit of patience, but it's pretty consistent and it's pretty robust, the website.
Now you'll notice the quality of the picture varies according to the light in the room.
And also the webcam
So
quality.
Diane has very good lighting and shows well, and they're not too bad, but
Barbara over here.
Barbara is.
I'm in the dark.
That's
Yeah.
right. So in
Most of the
whatever room
time.
you're in, you don't want
the slide.
backlighting, you want front lighting.
Right.
I'm thinking,
Now, if you go back to the screen where you had all the options, you
Yeah.
can show that's where you would stream videos or PowerPoint or PDFs.
yes. So we can make different pods in here. I'm not as familiar, so forgive me if something doesn't go right, but I can have. So are you talking about like a share screen or pulling up?
Shared screen where you run a video
Mm-hmm.
or PowerPoint.
Okay. So I've never actually done that, and now my video's disappeared.
Well, it's okay.
Okay.
But basically, the idea is, let's say you wanted to hand out a document at a meeting, okay? So what you would do is, instead of handing it out, you would share it on your screen, and you can bring it up and discuss it. Or you want to do a PowerPoint presentation, or you want to show a short video to illustrate something, you show it during the meeting. So basically, it's on your screen, everybody sees it, and then you pick up the meeting again.
Yes, I'm just not as
So
familiar.
that's all uploaded. These materials would all be uploaded,
Mm-hmm.
and so you would access them during the session.
And if you had a PowerPoint up, could Barbara, for example, save it to her computer so she would have it to her desk? Without sending it just because you're in this this common room.
No, what happened is the PowerPoint presentation would be sent on her computer. She would be uploading it to the website in order to show it during the meeting.
So if you had uploaded a PowerPoint when Barbara logged in, could she then say for her, we'd have to send it to her?
No, this is during a meeting.
Yeah.
Let's say during a meeting, you want to do a PowerPoint presentation. That PowerPoint presentation is sitting in your computer in a file, right?
And everybody's computer?
I think
No,
I
no.
think
No, just
you're
the-
talking
just
about
the
if I am the
Your
client.
clinician.
Yeah, no, if you're the facilitator.
Right,
Yeah.
that's what you're
Yeah.
talking
That's
about.
what, yeah.
Yeah.
But if-
Only
if you're-
the
for
facilitator.
instance, If I'm
Oh,
logged
no.
in and attending your
Patients
class.
can't.
No,
If you were using it for education, and I was sitting in your class as it were, unless you sent it to me, I couldn't then save it on.
No,
So-
you can't say that.
No.
This is all for discussion during the meeting,
Okay.
okay? But if you want to make it available, you can put it in resources.
oh, that's right.
Yeah.
I forgot about that box.
And then from resources, anybody can open it, print it, save it, do what they want.
Okay, thank you.
Mhm.
No, this is all about sharing it within a meeting.
During the session, so it can be discussed. So the videos went away, so you'll have to click start sharing again. If you want to join again, that's fine.
I have to click.
So you should see a video in the corner, in the top right corner. Do you see your webcam?
To start, you mean?
Yeah, start sharing. So that's how you come back. So I accidentally clicked out of it. But so that's generally, that's the general sense of the video conference. So as I said, sorry about the, the technical difficulties, but once people have set it up once and they've participated in a meeting, it's generally a lot, it's seamless almost, and we do have cheat sheets to guide people through every step of the process, including for the clinician, who sometimes are more nervous than the patients with using the website. And as Elsa said, she's not necessarily a techie person, and neither am I, and I somehow learned to use everything, so it's pretty simple to use.
So Joanne,
Yes.
The big gray space in the middle of my screen is predominantly used for documents and typing.
That's right. So if we're just
Not to
having
have the group picture in front of me. I'm not looking at a group.
yeah, if we're having a discussion, we do tell patients, we tell people to basically maximize the video. So you can do that by clicking in the top bar. There should be 4 outward-looking arrows.
Yes.
So if you click that,
Uh-huh.
your screen should go full
Oh.
size, the video camera.
Okay.
So that's
got
that's what we tell people to do when we're having a discussion, when we're talking. If we need to pull up a PowerPoint or we want to write something down, for example, with the whiteboard, then we can ask people to minimize it, and then they'll have the full screen available to see the PowerPoint and things like that.
And which is the minimizer?
So it's the same button actually. It's
Oh, there they
the
are.
4 arrows.
It's funny, they disappear
Yeah.
and then they come back.
Yeah, you
So
have to hover over the bar.
hover.
That's
okay.
right, for it to
and
come
then you
back.
click and then it goes back again.
Exactly.
That's easy.
There
Okay.
are different layouts you can use, but I think
God, I like
yeah,
figuring
there's a lot of things to play around with on this website. Just to keep it simple, though, I do it this way. So that's essentially what video conferencing looks like. Again, an important part of the intervention is the use of the eCare website and the resources here. And the intervention manual is all here for the clinician as well. So patients find it okay. Patients are able to navigate the website, able to log in, and clinicians as well. Are there any questions from the Susan? No? Okay.
Okay.
So I might end the meeting, or do you want to leave it open?
Sorry?
Do you want to end the online meeting?
Yeah, we can end the meeting.
Okay.
And just go back to the homepage and the website. So, what we'll do now is we'll set up a program that you want to offer, okay? Ask they'll hear me, the
Yes.
folks who are online. If you have an idea of an intervention program that you would like to offer at your institution, what we'll talk about is how you would prepare the doc, structure the program to function on the platform. So you have to see this as a platform that we happen to be offering 2 evidence-based programs on, one for caregivers, one for people with chronic disease. But you could have a program that you want to offer to people with arthritis. And how do they manage arthritis pain, okay?
Mm-hmm.
And so what would you need in terms of content to be uploaded to the platform, and how the platform would work for you to deliver your program for that particular population. Okay, so any ideas? Anybody online of a program they want to design?
Not yet. I've asked the question that you've just asked, but no
Okay.
one's replied yet.
Can I
Either of you have a, yep,
Can I give you an example? You
Sure.
tell me if I'm on the right track or not.
yep,
I would love for individuals to know how to do a home safety check for the prevention of falls, for example.
what individuals?
Say someone who is Parkinson's and has difficulty because of their
No,
mobility.
but who's to do the check?
Actually, the caregiver
patient
or
or-
the patient.
Patient or caregiver?
Mm-hmm.
Okay.
To do their own home, and this would be because access to an OT or someone
Yep,
might be too difficult, or it's done once, but they really should be, as their symptoms change, or as, right? Is
Yeah.
that the kind of thing?
you can, but that sounds like, information that you could send them. Is there something more to it?
I see.
Are there concerns that they wouldn't understand it, or do the,
Yeah, I'm envisioning not steps written, but maybe it's a video that goes with it. I don't know, but I think what you're talking about now, I'd have to rethink this as to what the how-to program.
see what, when you think of an intervention, you're thinking that there's something here to be known and executed. Okay? And that's what okay, so they need to know what to look for, and then they have to execute,
Mhm.
right?
Mhm.
And so then that then looks at, well, what are the difficulties,
Mhm.
in getting from point A to B, which
Mhm.
is what you want them to do, okay? So then you could conceptualize it as an intervention, and it would be the same thing as we have here. You would have an information handbook of some sort, and in that you would indicate what are these various home improvements, whatever,
Mhm.
sort of what are the risks, and in that handbook you could have pictures, you could show why carpets have to be cleared out, or handbars in bathrooms. I mean, you could have it all laid out in the handbook, okay? So then you could say, okay, you can access that and check your house, and list what needs to be done, and what are the problems in terms of achieving it.
Mhm.
Then you can meet online with them, either individually or as a group, and address, well, how do you go about it?
Mhm.
Okay? Is it financial? We can't afford to have it done. Or that won't fit in the area that we have, or, whatever
Mhm.
the challenges are, you can then discuss and problem solve.
Mhm.
So, and then you would outline that in a little intervention manual, okay, as to what you would do, okay. So you would really set it up so that they get the information, they try to apply the information, and then they meet in a group to discuss, how far along they're getting, what are the problems, and how you can help them. And that can be structured, you know, in a little intervention manual. You can say, okay, let's do 4 sessions, I don't know, whatever. I mean, you know more about the population. And you can do it all online. And of course, doing it in groups is much more parsimonious than a one-on-one. One, they learn so much from each other. They're really much smarter about their concerns and their disease than we'll ever be, unless we've had it ourselves. And so we find group really works very well for that. So does that make sense?
Very much so.
Okay.
Thank you.
What was your evaluation when there was the incidence of falls or the uptake of learning?
The evaluation of this?
Yeah.
Well, it depends what they set as what needed to change. And basically, that's pretty concrete. You know, let's say they had to install bars in bathrooms, okay? Were they able to do it? Secondly, you could just ask them, did it make them feel more secure? And you could have even a little scale. How much more secure do you feel now? Okay. But also you could track instances of falls. You could do a bit of retrospective. You know, how often have you tripped in the past? How often have you slipped in the tub, or you know, whatever. And then after the installation,
What was the change?
yeah. But remember, whenever you're evaluating anything, make it very specific to the intervention. Often we're very fuzzy, foggy about what the intervention targets for change, but you need to be very specific. If this is what the intervention is targeting for change, did it change? And then you can evaluate it. So, like for instance, for our caregivers, one of the big things that we track is distress related to caregiving, ADLs and IADLs. And that's a lot of what the intervention is all about. You know, what I talked about earlier about the emotional barriers. And so if you can show that their distress levels have changed, then you can say the intervention had something to do about it, because that's what we targeted. Okay. The group online, any program they'd like to offer?
No one's chatted about one yet.
Okay.
One of the other ones I was also thinking of was a program for managing fatigue,
Mm-hmm.
and with the goal of maintaining independence.
Fatigue related to disease or something?
Mm-hmm. Well, it could be related to caregiving, but related to disease process, and how one.
Well, I
does
spell
that.
it out to you.
Okay.
It's called EXERCIZE.
What did you?
You
what
mean
is it?
SE?
Exercise.
Okay. Yes, I know what you're saying in that regard. I guess I was thinking of more managing where certain activities are more energy using, and how you balance those through your week, how you.
It's all rehab.
It's right.
It's all rehab. So basically what you have to be able to identify is a rehab program that would help these people deal with what they're describing as fatigue, but it has a lot to do with mobility, energy levels, which is also related to diet, also related to emotion in terms of, you know, if you're depressed, chances are. So all of the, in other words, you can't just say fatigue. It has to be related to, well, what's the fatigue about? Okay.
Okay.
And then you would target your intervention to deal with it. Okay.
Is there a program for me for fatigue?
And for instance, arthritis also is such a global term,
Right,
you
it's
know,
huge.
and also in terms of what type of arthritic issues they're dealing with, what part of the body, and all of these things. So basically, you really have to have some expertise or have someone who's expert in terms of managing arthritic conditions. And whether that's rehab, some medication, or whatever. And then the issue is, as we do with all the chronic disease, are you implementing these rehab behaviors? And if you're not, how come?
My page had frozen, so I'm just trying to see if I can get it back so I can find out if someone did, in fact, have an intervention.
One of the self-management protocols we set up, not using online, was the management of a wound that's never going to heal.
Mm-hmm.
But you have to manage it yourself.
Right.
And that was taught face-to-face, which was fine. But one of the things we were concerned with is how do you continue to engage that isn't face-to-face, but deal with some of the barriers or the issues that is making someone feel successful or not.
Yep. Do it on the platform.
Yeah, I think the wound one would be a good one for that.
Yeah, especially with the video conferencing, they can have the camera on the wound,
Yeah.
you can see it. You can do videos of wound care, which you can show that they can repeatedly look at. But mostly what they need over time is support.
Yeah.
And you can provide it, and preferably again in a group, and they can provide it for each other. And you can schedule meetings, kind of intermittent, monthly, let's talk, or every 2 weeks, let's talk, how's it going? Because this is going to be ongoing.
Because it's ongoing,
Yeah.
that's right. Yeah.
Yep.
Valerie did ask for Alzheimer's caregiver support. Is the current program available? And she also has
Oh
more
yes,
to say.
I should spend some time talking about that. Okay. All of this was developed under research conditions. Okay, so all the studies and so all the experiences we're talking about is all been research. But now what we're doing is NICE, this place, is going to own eCare. And they're going to distribute it so that it will be available to clinicians. But through institutions, we will not license it. It's going to be licensed, and it will not be licensed to individuals. It will be licensed to institutions. And so that you can access the programs, the 2 programs that I discussed today, okay? And have access to all the materials, the video conferencing, and so on. We're just in the process of working out the license agreement and the fee as to what it will be. And we expect the fee will be according to users, the number of users. So if an institution has 1 user, the fee will reflect that. If they have 2 users, it'll be double. If they have 3, and so on, okay? But what that supports is, 1, the platform is on a server, which is monitored all the time. You have access to all of the materials and so on. And also, we pay Adobe Connect software license, and we pay according to user. So the licensing fee would cover that.
And sorry, who's the we?
We,
Who
NICE,
is- Nice. That group.
NICE. It's these folks.
Okay.
Okay, they're the ones who now own it. But the licensing fee won't be, let me put it this way. It costs us $5,000 a year for 10 hosts on Adobe Connect. Okay. So as soon as we license those out, okay, you get a host, you get a host, okay, we've got to then add more. And so we've got to cover the costs. That's just basic of Adobe Connect. In addition, we have to cover the cost of the server and the tech support we would provide. But we haven't, established the fee. But I would expect, I hope I'm not going to regret saying this, that would be less than $1,000 a year per host.
And Valerie asked, is a user the clinician or a client?
The good question. We like to, in terms of licensing, it's the institution. In terms of the delivery of the intervention, it's the clinician, and then the client is the recipient of the service, or the participant. In some sense, they're all users, but we distinguish them between the institution,
Paid user and an
the
unpaid user.
clinician, and the client or patient or caregiver.
She also asks, I'll go back to what she asked the first time, but right now she also asks, would the Alzheimer's Society be an institution?
It would have to be one of their offices, not the whole society. And I think that poses a problem for them, actually. Yeah. So I think it would be an office of the society that decides they want to adopt the program, and it would be licensed to that specific office.
And she says, if we have Adobe Connect already, how does that change the fee?
It doesn't.
And earlier when we were talking about programs, she said, first of all, Alzheimer's caregiver support, is it available? Then she asked also, stroke programs such as the time exercise program could be extended with a video component, or it could be used to bridge the time between face-to-face programs.
I don't know what time exercise program is.
I'll ask her to tell us more.
That's due. Some of the stroke programs are time limited, so regardless of where you are in your recovery journey, you only get so many hours. And I wonder if that's to be done online.
Yeah.
I think it's actually the name of a program, like an acronym. I believe, but I might be wrong.
I'm not sure that's
Time program for stroke?
Yeah.
Yeah, I don't know it.
Maybe to extend that
What
online.
I want to make very clear, our chronic disease program are for people who are non-adherent to rehab. It does not instruct rehab. It does not provide a rehab program. It's people who are non-adherent. Okay, in other words, they've been prescribed to change some lifestyle behaviors, and they're not doing it. Okay. So for the answer to these folks, if this is a particular program, what our platform would be for people who are participating in that program who have dropped out or who are not adhering. And then we could, this program would be getting at, well, how come? And what can we do to get people back on track?
She says, a community program with regional stroke delivered in different ways in our community at the YMCA.
So what was the question?
Can you tell us more about time? You said you didn't know what time
time?
was. The program she mentioned.
Yeah, but what was the initial question? How could the platform be used?
Sorry. So we asked, do you have a program you want to see go on to eCare?
Mhm.
And she said, for Alzheimer's, caregiver support is the current program available. Also, stroke programs such as the time exercise program could be extended with a video component, or it could be used to bridge the time between face-to-face programs.
That's her suggestion.
Yes.
Yeah. Well, my answer is what I just said. In other words, this program is only for people with chronic disease who do not adhere to the rehab regime. It does not provide a rehab program. It's for non-adherence.
Oh, she says the non-adherence happens when they leave the program. Motivation is a large problem when at home.
It's the
In which
sustained-
case, then the program could be used. In other words, it's exactly to deal with people who do not maintain their rehab when they're at home. And to understand, in this group context, how come? And then how can they now reset goals, because that's what they learned in rehab. They reset goals and plan the steps to reach those goals within the group context. And then they look at, well, what gets in the way of executing the steps to get to the goals.
I missed that part.
So it's all problem solving. That's
Yeah.
what it is.
Yep.
Okay. And a lot of it has two things. It's the emotional response, frequently depression, and the other one is support, social support. I would say those are the two key factors.
And the group can help the individual problem solve,
Mm,
deal with the barriers that are stopping them.
that's right. In fact, we've had group members become exercising partners.
It's true.
Yeah. One thing that we
It's like
learned.
online Weight Watchers have started that online coaching for non-adhering.
Yeah.
Mhm.
Yeah. What we kept hearing back from a lot of both the caregivers and the chronic disease patients is what was most important was that they have a connection with one clinician they could count on at the service agency or hospital or clinic. That was really important. To just get a screen where you interact with someone, a clinician who answers your questions or whatever, didn't do it for them. They just felt they acquired a sense of trust and connectedness by identifying one person. And that facilitator who runs the groups becomes enormously important, as well as the support they get from each other.
You know me.
Sorry?
You know me.
Yes.
Yeah. Yeah. And a lot of these online programs that are interactive but are not, they don't develop a relationship with a clinician, which is much enhanced using video conferencing, in the long run don't work because there is not that connection.
Makes intuitive sense.
Yeah. The other thing is, I really don't like the idea of caregiver anymore. I think we need to now increasingly talk about care partners, and there are three. It's the patient, it's the family or friend, and it's the healthcare provider.
Okay.
And if you don't think of it as an equal responsibility partnership, it doesn't work.
No, it's good.
And so you don't want the patient to be dependent on the healthcare provider because they really largely have to depend on themselves. Anybody with a chronic disease, 90% is self-care. And they have to really understand that. They are taking responsibility for their own care, and healthcare providers have to acknowledge the fact that they can't provide the care. It's minuscule. And family and support network play an important role. Okay, any?
Very good. Thank you.
Excellent, thank you. A lot of food for thought.
Yes. And if you are interested in licensing and trying it out, then you'll get in touch with NICE, and I don't know who, maybe Raza will be dealing with it, but basically just go to the website
Yeah.
and you get a chance to try it out.
Thank you.
And we have several, it's going to be available to both clinicians but also to researchers, and we have a couple of researchers who are developing programs they want to evaluate. One is for parents of children with autism, and programs for the parents, very little for parents of autistic kids. They also huge delays in getting the children diagnosed, and not many programs for the children. So they really want to use the platform to develop materials, intervention programs for that population. And the other one is, I think one of you mentioned, self-care for people with Parkinson's. Another project that are interested in doing that. Now, hopefully, once these get developed, they will be available on the platform.
That's all I
That's it. No questions, nothing? Okay, well, thank you for coming, and
thank you.
I wish you lots of fun engaging in technology and providing care.
Thank you. Thank you, Elsa.
Okay.